Hey everybody, it's Sandy Lee from Lighthearted RDH. Get ready for your unofficial dental hygiene podcast. Here we go!
These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists. Welcome back to episode 98 of A Tale of Two Hygienists. This is Michelle.
And this is Andrew. So, buddy, 98. You've been busy, though, between episodes from 97 to 98.
It's been a lot happening. This is month of November is going to be crazy for me. I think I'm home like 4 nights or something this month. And that's like literally not a
That's sad.
joke. It's all right.
Empathetic.
Good things.
Sad empathetic. I
was just at the College of Prosthodontist meeting, which was a really great meeting, minus the fact that they wouldn't allow exhibitors to eat food. I swear some of these shows hate exhibitors. Even though we make the show, you don't pay a lot of money because the exhibitors do.
Yeah.
You might think your $100, $200, $300, whatever your fee is a lot, but it's thousands upon thousands of dollars for exhibitors to be there. Just remember that when you feel like they're being cheap with their samples or whatever it is. It costs thousands of dollars. And for instance, if they're selling toothpaste, it takes a lot of toothpaste to recover thousands of dollars. So just keep that in mind, folks. But I swear some of these meetings just hate exhibitors. They're like, no water for you, no coffee for you, no food for you. I literally got yelled at because I took a muffin, which is normally a thing. They put the food out, you grab a muffin, especially when the exhibit starts at 7 a.m. Mm-hmm. It was frustrating, but good show.
I overheard part of your guys' conversation when we were talking on the phone that one day, and the anger in your voice when I think it was Edgar or whoever it was you were talking to, but you're like, yeah, you can't even eat lunch over there. They wouldn't. It's just different people than from breakfast, and they wouldn't let us eat lunch.
I was so mad.
It was so funny.
I was hangry.
I was just like a little
That's
fly
what I
on the
was.
wall.
I was
It was
hangry. Anyway.
Yeah, everyone look out.
But it was in San Francisco, and I like San Francisco, but I love Sausalito. So I got to go hang out in Sausalito one of the afternoons. So that was great. And then I just came back from Dr. Christensen and the clinician's reports. I don't know. Do you ever read those?
Not anymore. I used to more when I was brand new. Mm-hmm. I think that they're awesome. And sometimes we get things sent to our office that's an insert from one of the companies that was featured in there, and then they send it out to all the offices and things like that. Do you realize what a big deal it was to meet Dr. Christensen?
So I've heard.
I feel like you don't know the dental world at all. You're like, yeah, it's just another person, blah, blah, blah. I'm like, no, this is the Gordon Christensen.
Yeah. Well, we've said this before. I never really actually know who I interact with. I just know if I like you or I don't like you, and that's it. That's where it ends for me.
Yeah.
But yes, he very cool. What I enjoyed was that I got to tour their research center. And so I didn't realize, I just thought, I guess I hadn't been reading them very much in my career. Never was in restorative. And I always felt like that was more geared towards restorative, like cements and bonding and blah, 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 that kind of stuff. And I just never really read it. I knew what it was, but to me, it was you had to buy into it almost. And it just didn't seem true and altruistic to the research side of things. But their research center was incredible. It's nonprofit. Mm-hmm. I mean, I sat there and watched temp cement for implant cement to see at what pressure it would crack, so that they know if it would take off the crown, hold the crown, but still come off without damaging the abutment and things like that, or the crown itself. I know, it was so cool. So I really did appreciate to see another side of that. And learn a little bit more about it. So his wife, Dr. Gordon Christensen's wife, Rella, is also a dentist and has a specialty in microbiology. And for their 50th wedding.
Did she used to be a hygienist at first? Do you know?
I don't know. I wish I had gotten a chance to
been.
meet her. That would be cool. But for their 50th wedding anniversary, she asked for an SEM, which is thousands, a scanning electronic microscope. And
Microscope. Mm-hmm.
I was like, that is marriage goals for me. Like, I would actually consider marriage if I thought I could nerd out with somebody and we could just constantly buy dental equipment. Like, I have a problem.
That's adorably, that's
Adorably
wow.
ridiculous,
Good
and I
for
have an
you.
issue. So that was fun. That was
Yeah,
fun.
you do. That's okay though.
Yeah. Anything fun for you to report?
So, no, nothing really for me. I've just been working a ton. You know how it is when we don't have traveling, then I can put in more overtime and make more money. So
Nice.
you know how it is. That's good. And I can't, I can't really talk about my company because whatever, but we just got a new benefits. Like it was reevaluated and like we got new benefits. So, one of the perks is that our licenses will be paid for.
Oh, okay. That's nice.
And I know that sounds stupid,
No.
but because it's only like $50 in the state of Washington, but in Oregon it's like $350
Whoa.
every other year. Yeah, it's super expensive, and I was complaining about it before, and I'm like, but anyways, like our company pays for stuff like that. Like our company is they think so outside of the box on little things like that you would never even think about.
Well, I got mine paid.
Like, that's awesome.
I've never actually paid, not until I wasn't employed by a dental office did I pay for mine. Like my whole,
Really?
yeah, I've always negotiated that into my benefits.
I think you're a better negotiator than all the rest of us then. Or maybe I'm the wrong one.
Well, I don't know.
Email us, let
It
us
was
know.
something that I was told was like a normal practice. So I just kind of, I guess, probably went in there all ballsy like because I just assumed that was a thing. I was like, okay, I would like my scrubs paid for once a year. I would like my CE up to this many. I would like, I don't know, like
my ADHA fees, my
yes,
license
I got my
fees,
ADHA fees. I got my licensing fees. Like I got all of that
course.
stuff. But I was just like, give me these things because I'm going to perform for you. And that's just what it was. Like, I don't know.
A lesson to all you listeners out there. That's what you got to do.
But
Negotiate
also,
into
I
it.
hope that I didn't go in there like I did not try to be a diva about it. Like I deserve these things. Like I'm entitled. Like not like that. Like listen, I'm going to work hard. I'm going to show up. I rarely call out sick. I rarely don't come up to work. I bust my butt. I'm an assistant and a hygienist, so I can play a lot of roles. I'm very computer savvy. So these are the things that I would like to have from you, and I will work hard, for you. So. But I also valued what I did for the office, and I don't know, I just was lucky to get that stuff, but that's great. I don't tell anybody else your other benefits because I'm pretty sure everybody would like backhand you. The rest of the world does not get those things.
No, they don't. It's awesome. But yeah, I'm lucky to have my job. So
Truly
loving it.
We didn't get like a lot of listener feedback this week, but I did get some private messages. There's little things that I learn at these meetings that I sometimes I just ramble on about the cool stuff that I learned just because I like to nerd out over it. But occasionally it hits somebody and it enlightens them. And one of them was xylitol and SIBO, the small intestinal thing that I learned when I was at AOSH. And somebody had just been diagnosed with SIBO, was starting to feel kind of yucky again. And she was like, it's probably the 50 things of xylitol I eat every day. She's like, I didn't know. She's like, I had a horrible night last night and I didn't know that was a thing. So for those of you that get annoyed with me nerding out sometimes, I'm going to have to ask you to deal with it because there's going to be the few people
just endure it
that actually take something from it. I think that
if
was
I
all
can
we
do
got.
it for 98 episodes, I feel like everyone else could probably do it every now and again.
And not just the 98 episodes. Like we talk multiple times a week.
Yeah, that's true. Yeah,
So
absolutely true. All of those things. So yeah. So anyways, our interview today.
Yeah.
Great interview. Different interview. Maybe it's a little bit different.
It is a little bit different.
What our normal.
And
we have Michael Ventriello.
Yes. And I actually knew him
right.
because he does a little bit of work with Dr. Highland from Aura Vital. And I think he's even doing some work with Patty DeGangi as well right now.
Yeah.
But he
mentioned that
he's
on
not
the episode.
an
Yeah.
actual dental professional. He's kind of the behind the scenes person. But he wrote an article that I thought was really interesting, and we talk about it in the episode. And that's kind of why we asked him to come on, because we have all gone to exhibits, and I don't know who used this term. It was just on one of our podcasts. But we come back and we like fire hose our office with all the knowledge and all the products. And we need to have something to help us focus. Why are these products good? What would make them valuable to our office? What is their research? All those different things, so that we can come back and have a strong and succinct conversation with either the doctor, the owner, the assistants, the front desk, whoever it is that's going to be. You need to get on board with it. So he had some great suggestions. Enjoy this episode.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
All right, welcome to another interview here at RDH Under One Roof 2017. And
Okay.
I'm starting. Is that okay, Michelle?
Yeah, no, okay, go ahead.
Yeah. And this is interview number
7.
7. So we're very well rehearsed now.
Yeah.
But one thing too is we didn't have an interview, so we appreciate you coming at this late hour.
I know.
and
We've
jumping
done
in
a
for
lot
us.
of last minute, and we really appreciate that from everyone.
Yeah.
Because
Well, that does make me feel special.
That we made accommodations for you, right? Not
Yeah.
that we're scrambling
That
for
you-
people, right?
Well, it was
You
one of those
bump
things.
somebody
I
off
know,
that.
right? That's exactly what
That's
happened.
yeah.
So, yes, we're at RDH. We will let you introduce yourself and tell us a little bit about your role here in dentistry.
Sure. My name is Michael Ventriello, and I have a marketing consultancy called Ventriello Communications. And my main business is business-to-business marketing in the dental industry. So what that means is I work with dental manufacturers, companies, to market their products to dentists, hygienists, office managers, what have you, dental professionals.
So is this like when newer products are coming out, existing products are coming out, trying to create hype, or just trying to create personal connections? What specifically?
Really,
do
all
you-
of the above.
Is it?
I try not to say hype, because hype kind of connotates that there's something not true or unreal
Okay.
or not, there's no
Or
foundation to what.
trendy at that moment,
Yeah.
not long lasting.
I like to work with innovative companies. I mean, that's really what floats my boat. So, if I see a company and I say, wow, that seems like that solves a problem. Now, I'm not a clinician, but I've been in this business specializing in dental for about 10 years. And as a patient, as an educated patient, I know what I like, what I don't like, what I wish the dentist or hygienist might do. And if I see something innovative, I'll contact that company and say, maybe I can help you get the audience you want and help you build your business. And that gives me a lot of satisfaction. It's almost like, the thrill of the hunt, for lack of a better word.
Sure.
Yeah.
Do you have an example of someone that we might have heard of before, or our audience
Well,
may have heard of?
in the past, I've worked with companies such as Oral DNA Labs back when they were first launching. I worked for another company at the time, but I provided PR and marketing communications. Right now, I'm working with a company called Aura Vital. They're based in Canada.
And we've had them on the podcast, Dr.
Right,
Hyland.
Dr. Hyland. And I thought they were unique because they had the diagnostic side for periodontal disease,
And the treatment
but then
side.
they had the solution too. So based on the lab report, they would tell you what oral antibiotic you should prescribe. And oral antibiotic meaning a rinse, not a pill, which has systemic side effects. And there's been a lot of talk regarding the antimicrobial resistance There's something like 180 companies that signed a charter recently to do all they can do to control this and not over-prescribe. Nice. So this really is kind of the antidote to that. So, of course, that intrigued me, and I'm happy to, help a company like that change the thinking a little bit. And that's what you are. You're really a change agent working for change agents.
Helping the change agents make the change.
And it's very exciting. Sometimes there's a lot of client expectation management because of course they want everything to happen quickly. But whenever you're changing human behavior, whether it's clinician behavior, which also has to drill down to patient behavior, that takes a lot.
It does.
It takes consistent messaging, education, and it's all communication, really. I mean, you can have the greatest product in the world, but if it's not marketed correctly, you're not going to win in a marketplace. And one of the examples I use is back in the day of videotape recorder. The best format as far as quality was beta. VHS won that war because they made deals with the manufacturers, the companies that made the recorders and the playback units, and they signed the deals with the movie studios. So, and plus they put a ton of money behind it. So they won out of default, but the aficionados of video quality and production said, how could this be? Well, they were out-marketed. Now beta is the standard in professional news and stuff, but it never made the leap to consumer.
Interesting. The back end of this industry is really fascinating. It really is. And to understand how some good products are just never made it just for pure marketing, or even, and we keep getting on these trends of the whole weekend that we could talk about some of the very similar topics, but why can't products be in the retail, or why can't you just quickly develop this one thing? That's all I'm asking for is this one thing. There's just so many little things, and the sales, the marketing, the numbers, the need, the demand, all of that goes into it, and you never think about that as a in the mouth, in the trenches kind of hygienist.
Well, there's a lot of variables. One of it is budget. I mean, how many times, and you probably know people, they have a great idea, they scrape their life savings together, and they get a prototype, and they bring it to market, and maybe they get a booth at a show, out on the perimeter somewhere, and they just can't get traction because, one, they're underfunded. They're competing against some big dogs in the industry, and they're getting bigger with all the acquisitions and the mergers. So it's tougher. But in my biased opinion, one of the things that really hurts them is they think of marketing as an afterthought. And marketing should be addressed, and you should bring it into the thought process at the very beginning. From when you're naming the product, deciding who you're going to sell it to, what the distribution channel is going to be. A lot of times I've been called in and say, okay, we have this product, and the name is just awful. And it's like, oh man, I wish you'd call me sooner. Why,
Here we are with this name. What do I do with this?
And it's trademarked, and they have a gazillion boxes printed up, or whatever it is. So you have to think marketing at the genesis of the idea.
That's interesting.
It'd be kind of it might be too on the nose. It'd be kind of fun is to go through all the dental podcasts and look at all their names.
Well, even Alan Mead has talked about dental hacks, how it has a negative connotation,
because
a hack, you're not good at it. But it was supposed to be life hacks, here's some things. But he's talked about that before.
Yeah, and we've had to rename ourselves
before
I know. Because of just things that happen.
Like the name was already taken.
But we were given permission, kind of, to use it.
We won't talk about it. But What do you think about our name, though, as an industry expert, A Tale of Two Hygienists?
I like it, and being an English major in college, I appreciate it.
All right, you passed the test. That was a good answer.
It's very literary. It's very literary.
It is.
We went back and forth with names. That was definitely not our strong point on this side of it.
But I feel like, we tried to, really think about the marketing down the road of, hey, this is going to be out in the middle and the internet for forever. Like, what do we want to be known as, and what is something that people will remember, and what are some other questions that maybe that we should have thought about? Like, what other things do we go into naming? What questions should we have asked ourselves?
Well, naming, how much explanation do you need? I mean, a name should
sense.
smack someone in the head, and I know what that is.
Yeah, good point.
Sometimes you could take a name that may not be obvious, and then you'll put a tagline or a slogan, but that should be supportive, but the name should really be what it is. And now you have to have a URL that's your name. So it's like if the URL is taken for whatever reason, it's like, all right, let's go back to the drawing board and come up with something else.
Yeah.
So.
Yeah, actually, I've done just that last month because I'm starting another podcast, and there was a dental in any URL is kind of already taken in some way. So I was like, well, what about this? What about that? Just going through GoDaddy.com and like, what about this?
And you don't want to paint yourself into a corner either, because if it's so specific, then you end up a couple of years later, Acme Floss Company, we're not just floss, because they had a product extension.
Right.
So you have to think of, where do I want this company to be? Is there a possibility that there might be some other products that we throw in the mix that, aren't out of left field, but make sense.
Right.
And they're complementary. So you have to have a short game and a long game in your brand strategy.
Interesting. That's a good idea. So we always have to have two people on this podcast. We are a tale of two hygienists.
She's been auditioning for a new co-host to try and kick me off the podcast.
You made me mad.
But that's why that name works.
That is right. So she can't get rid of me completely. Well, she can get rid of me, but she needs another co-host.
Yeah.
Because the Three Stooges were still the Three Stooges, whether it was Curly or Shemp.
Yeah.
Not that you're Shemp. But
no, I mean, I understand where you got that from, but it wasn't a far reach for that.
Far reach at all. So you're doing marketing for dental company. What you doing at a hygiene show?
Well, I'm working with Patty DeGangi. She's a key opinion leader in the hygiene sector. Everyone knows her.
We've had her on. Yeah, Codology.
Yep. And I'm helping her market a new initiative, which is the Dental Codologist membership community. And what that is it's a subscription-based program where every month members will get a newsletter, they'll get access to CE webinars, mastermind calls with Patty, things of that sort. So there's just a lot of benefit that will keep somebody really up on what's going on in dental coding.
Nice, very nice.
And, there's a lot of changes. Not a couple of months ago, they had the gingivitis code, which is really a game changer, just how things are diagnosed and treated. So it's not going to change. It's just going to get more complicated, and you want to make sure that you're submitting the claims correctly. Whether they're reimbursed or not, you should have a code for everything you do.
And that's what I think a lot of it comes down to. The game changer, I think, is if you're doing it properly.
Right.
And you just don't continue to go, oh, but the insurance not going to pay for it, so Profi it is.
And once again, I'm not a clinician, but I learn so much from the people I work with. It's just like I'm just a sponge. And it's just like, you really want me to explain this to you? I go, yeah. And I'll just like, yeah. And I'll take the notes and whatever. And, sometimes I'll just repeat stuff back. I say, remember you said that? And I go, wow, you were paying attention.
You were paying attention. Look at that. Yeah. Absolutely.
What we see all the time on the forums about, hey, what code do I use for this particular situation? So I feel like that would be a needed, a very, very big asset, I think, for the community to be part.
I mean, I could only think that standardization is a good thing when it comes to that. It shouldn't be some form of interpretive dance where, it differs from practice to practice or from clinician to clinician, from operatory to operatory. I mean, how do you run any business that way?
No,
let
exactly.
alone a dental practice. So, based on what I know, it makes perfect sense.
And I think the end outcome is that the patient's going to get healthier because of it. They're, like you were saying, just not treating them based on insurance codes, but on whatever we're finding clinically, and is using the right codes for the right treatment.
Because what if we put it back to the patient, and if they get fussy with us because, well, my insurance is going to pay for this, like, we'll call your insurance company. You're paying them. You should be getting treatment that is right for you. So, I mean, what if instead of us like tiptoeing around like making the patient mad, why don't we get the patient mad at the insurance companies and like, you should be paying for this,
right?
Like, isn't that what my insurance is for? And if they are the ones driving it, and not so much the dental profession, because we're just doing what we need to do to make you healthier.
Right.
If they're not paying for it, then you need to go talk to your insurance company.
Well, what if you looked at, and I might be totally out of line here, but it's almost
We
like
usually
that's what
are.
we like on this
okay,
podcast.
good. I'm in the right place. It's almost like casting a vote, because if the industry consistently codes for specific things,
You're telling that insurance company that this is what they are.
Says, like, wow, we had all these submissions for this particular code.
Maybe we should
that's
start
when
to pay for this code.
And I think that's part of the end game, to have everyone using certain codes. Because how are they going to know if there's a need, or whether they should start reimbursing for it?
Yeah.
Or,
Well, I think that's a really good point to make, because again, we go back to like put the patient, we want them to get the treatment, but they're not going to, like, but you understand, like, you're actually hurting yourself and the patient by not following through. And I think people don't always see it that way, because they're like, you're in the moment, like, I need to get this done. And the hygienists that are in the trenches every day, like, not going home worrying about codes at the end of the night, you know, like, but if we just kind of break it down and explain that to them, that there could be a change if we make a change, if we are pushing the change, but just settling for what we got or what the insurance is going to give us, in what world is that going to make a change? It's just not.
Right.
So understanding the why we have to do this, I think, is always very important.
well, if everyone does something different, that just dilutes
There's no consistency, right?
the cost, right?
No consistency at all, and I mean, it dilutes the cost. I think that's
And another way to think about it is, when you look at things in the terms of the oral systemic health link, insurance coding is a pivot point between medicine and dentistry, especially if you're doing the cross coding.
Yes. Yeah.
So if you're sharing records with, somebody's primary care physician, you have to document this stuff.
Right. So, for instance, let's say someone just had a heart attack or stent, or has a murmur, whatever reason that they're pre-medding, or let's actually just go with joint replacement. And you say, I need to do a deep cleaning, and let's say you were sharing medical records, and they're like, oh, well, we weren't recommending pre-med because you said that they were a healthy mouth this whole time, because you put them at prophy.
Right.
But now you're saying they have disease. Not that that wouldn't happen, like, from healthy, but
sure.
Like, well, how long have they been diseased? Well, they've always had these 4 and 5 millimeter pockets, whatever. Like, well, what the hell? Like, why haven't you been treating them as a disease active patient? You've been coding. Maybe you're treating them that, but you're not coding it that way.
Exactly.
And so we can't see that side of it.
So you're diminishing the medical necessity of the treatment.
Exactly.
And dentists and hygienists, they do provide a medically necessary service.
Absolutely. Mm-hmm.
Every day, multiple times a day. Mm-hmm. So to diminish that.
Right. It's true. And it's like if you are looking at the forward-thinking side of it, let's say hopefully one day that we do have this cross-coding and they're looking at like, well, you've had active periodontal disease. Let's look at that before we do this bypass surgery. Like we could get that healthy and then move. So if we can start doing our part, like we're just kind of setting the stage for the future of this cross-coding.
And it's not only the future, but it's dealing with the present in real time. Because every time this emerging research is published, whether it was the Baldinine study that was in the British Medical Journal back in October or November, that basically said in no uncertain terms that oral pathogens are an independent causal factor of cardiovascular disease. So why wouldn't you want to code that and diagnose that correctly for the sake of the patient?
Exactly.
I know. It's such a frustrating. It's like it makes sense, but like, why haven't we made that change? It's so frustrating.
And I don't think anyone says, well, we don't want to do it, but I think it's a matter of not feeling confident, not
knowing how to make that
not
change.
how to do that. And there was an article in this month's RDH magazine on basically reevaluating the time that is allocated for a standard hygiene appointment, which it's
that's
not long enough.
No, we've been battling that.
It's
and the
not
people that
long
see patients
enough.
in 30 minutes, I'm just like, well, one, why? Why would you want to do that to yourself? Like, so if it's a healthy patient, I could probably get them done in 20 minutes. If I'm just polishing,
there's no patient advocacy built into that 30
exactly.
minutes.
There's none of the education, being an advocate, talking about treatment planning, talking about the systemic link. Like, and then people are like, well, if I have an hour, I'm like sitting there for 20 minutes. I'm like,
you can't
just
do it.
Quit your job now.
I'm
kidding.
You can't put 10 pounds of potatoes in a 5-pound bag.
Right.
And that's what you're doing with a high. Because, okay, what are we going to do? Oh, we have to do a salivary test. We're going to do oral cancer screening. There are all these things that in the last 10, 15, 20 years have become part of the the language of dentistry. We talk about it, we read articles about it, we go to lectures to see people speak with authority on these topics. Then when it comes time to implement, you're doing it in the same time frame as before the days of digital x-rays. So that has to expand. And that's really the front line of the dental, other than restorative work and things like that, and, cavities and invasive procedures. That's kind of like the baseline these days, or it seems like it's evolving that way. And you're not going to do it in a half hour.
Well, I think it also goes back down to the education. Like, how are our dentists being educated? How are the hygienists being educated? Are dentists even understanding what we're supposed to be doing in that appointment, or do they just see the revenue that's generated? Because sometimes it's very short-sighted in a lot of these cases. The reason it's 30 minutes is because they're just missing it, or they're just not accepting that something could be done.
There's more than the time. Not only does the time allotted have to be expanded, but the business model has to change.
Right.
So if you're taking on new patients, maybe insurance doesn't cover everything that the initial appointment entails. But your policy is, your first appointment's going to be 2 to 3 hours. And we're going to get a baseline of your oral health. And we're going to take, very detailed patient history records. We're going to share that with your physician, and then maybe in 6 months you have a typical hygiene appointment, which is basically maintenance checkup. But maybe annually it's a full hour. And that's kind of what this article in RDH Magazine was proposing. And it's like, duh, that makes sense.
So let's talk about other articles in RD. Well, this technically, was this in dental economics? What was this in?
Well, it was originally on
Dentistry IQ, right?
It's on Dentistry IQ, and it originally appeared in RDH Magazine online.
Okay. That's what I thought.
And eVillage. And great segue.
Every now and again, I lose a lot of them, but sometimes I'm a winner.
And it was an article I wrote. Thank you very much.
I got it here. It's a good title, and I had a hard time finding it. Like, you saw some great products at the dental meeting. Have you been told to curb your enthusiasm? And this is from July.
Right.
July's, and it's so true. So kind of, Andrew hasn't read it because I'm still not convinced he knows how to read.
I mean, I can count. That's like, and so I got the numbers down.
So Andrew hasn't read it first. So Andrew, that hasn't gotten there, tell us what that's all about.
Well, it's something I've been thinking about for a long time. I lost count of the times I'd be in a client meeting and trying to introduce a new product or system, therapeutic, diagnostic tool, whatever. And it's like, if we could get the hygienists interested so they could tell the dentists about this product, everything will be gravy. It doesn't really work that way. And it's really a lot to expect for the hygienists that you are marketing to if you don't give them the wherewithal to be an advocate for what it is you're selling. Because the hygienists will be interested, and I've known this by being at Chicago midwinter meetings, and hygienists come up to the booth, and they'll be interested in a demo on a laser or something like that, but they're not going to buy it.
Right.
They don't have the purchasing authority.
Right.
And they might wish they had that to work with in the practice, but if they go tell the dentist, say, I saw this great thing, we should buy it, we should use it, the dentist is going to...
How much does it cost?
How much does it cost?
How is that going to bring me more money?
Exactly. And that's,
I'm already at 70% overhead. All those
because
things.
The dentist is a businessman in addition to being a clinician. So it is, a tightrope.
It is. When I don't ever want to walk, that's a hard.
And you're dealing with insurance, you're dealing with HIPAA compliance, you're dealing with all these
staff
headaches.
management, all of that fun stuff.
So for someone saying, you need a $50,000 widget, talk to the hand,
right?
Basically,
right.
So I think the alliance can be made with hygienists and manufacturers to present information in such a way that the dentist will at least consider what it is you're recommending. And you basically have to present the business case for what it is that you saw. Why is this a great idea? What is it going to do for the patient? What is it going to do for the profitability of the practice? What's the win-win? It's like, yes, the patient care is important, but we can't lose money doing that because then we'd be in public health.
Right, exactly.
Right? And it's a business. So that was the premise of the article. And basically, trying to make the point that you have to speak to the dentist or the practice owner as another business person and lay out the proposition in a business manner. So part of the article was a template that I developed where you could just go through, the line items and either check the box or fill in the blanks and give that to the dentist. It's almost like a call report that a salesperson would use when they meet a client, and you attach that to the brochure or whatever it is. And once he reads that kind of that Cliff Notes version of why this is important, then maybe he or she will take the time to, read the literature.
I like that.
Call their distributor rep, bring them in and explore the product or the service in greater detail.
Mm-hmm.
It's no longer just a fleeting, quick conversation. Now it's something that they can act upon.
It's something a little more methodical. It's not like a drive-by. Here are the brochures I got.
Right.
Boom.
Right.
Yeah. Because I do know that's what we do, yeah. We get excited when we come to conferences and see things and go back and then, hey, doctor, this is so great, blah, 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 and just like spew everything that we
and it goes to the flip side, too, when the dentist goes and gets like, we're going to start implementing this, and we're just like, ugh.
Right.
What about this? What about that? That's not going to work. So it goes both ways for sure with these things.
And it all comes back to the 30 minutes that you have per patient, right?
Right,
yeah.
right.
Yeah.
So this is nice because you kind of have it where, well, honestly, what it feels like, and which we've talked about, and I've even written an article 2 years ago, like talking about being on this side of the table as a hygienist, and how we need to stop treating the exhibit floor like it's trick-or-treating with our little bag. Give me my free samples. Like, why am I not getting as much toothpaste as I did last year? I'm like, really? You can't go buy your own damn toothpaste? So I think it's about a paradigm shift for the exhibit floor, honestly. It's, going and learning. Because, when you are an exhibitor, I'm not just a salesperson. I'm a hygienist with 7-10 years of practicing with this product and a ton of research that I would love to tell you about. But you just came for your free sample, and you're not going to learn anything from me. So, use these people that are at the table to help you get that product at your office if this is really something that interests you. And this kind of just takes it to that next level. So stop using the exhibit floor like it's, I got to restock my bathroom, and all my friends that come in from town now all have toothbrushes and whatever else. Or stop leaving your samples in your drawer and oh yeah, that's right, I did get that fluoride varnish that one time and I'm running out. Let me just use it on here. You don't even try it. So take it and learn something about it and help yourself look at those companies from a different way versus just being samplers.
And plus, the psychology of an employer, it doesn't matter if they're a dentist or, they own a car dealership or whatever it is, they want the employees to care about the business.
Mm-hmm.
Yes, they do.
Yeah,
because,
I agree.
Because the health of the business is what's, helping you earn a paycheck, helping you buy groceries, and, it's not an entitlement. But if you care about the business and you say, doctor, I saw this demonstration, it was very impressive. They have a lot of research. It would save us time. It would, we would be more effective because it's more accurate. Whatever the benefits are.
Yeah. Well, and I think
I want to look at the article. Sorry. I'm not trying to be all.
I'm what are you trying to do? You don't know how to work an iPhone.
I don't actually.
No, you threw me off.
Sorry,
Andrew.
I know I always do that.
Say again what you just said.
But
maybe it'll come back to me.
But an employer wants to know that you care about the business.
Right.
That you're not just all right, where's my paycheck? I'll see you Monday.
Like an entitled
whatever.
diva of a hygienist, which we always get that bad rap, unfortunately. And I think, though, where the gap is not bridged between the business dentist and the emotional hygienist is that patient care. So if I used this and I was well, let's take a fluoride product. Okay, it's $1 more per application, but you're seeing it from the dollar. I'm seeing it from that emotional. Mm-hmm. How can we bridge that gap between the two? My patients aren't going to complain that I didn't clean their teeth because their teeth don't feel so gritty anymore. I'm not going to fuss because it's clumping anymore. So yes, it's $1, but it's going to save me time. Patients are going to leave happier. They're not going to be frustrated because I just cleaned their teeth. They don't feel like they have clean teeth. So this $1 is going to be worth it in the long run.
Right.
So it's about helping, I think, hygienists bridge that communication gap or that feeling, because one's coming from an emotional side of it and the other's coming from a business side of it, and appreciating both ends of that.
So let me ask the two of you, what are the main pain points in the day-to-day of practicing hygiene?
What's the most difficult?
Like, what do you like? What is the most aggravating thing? I mean, is it is it efficiency? Is it patient compliance? I mean, I'm sure those things factor into a lot of what you deal with.
Honestly, for me, I mean, I work in the Shangri-La of dentistry. I'm very lucky where I work, and it's pretty sweet. We have almost anything we ever want or need. We have it all. We have systems in place to really get our patients healthy. That's the focus of the whole entire practice. It's pretty great. But I would say the only thing that's maybe the pain point on my end is not any doctor specifically, but doctor time management. Newer, been there for a while, established, whatever you want to call it, it doesn't really matter. It's if I'm still waiting on you to come do my exam, and I have 5 minutes left and my next patient's already here, but I don't have another room I can go to. That's kind of those are my problems.
It's going to put you behind.
It's time management and that kind of stuff.
You hurry up to wait.
But again, I work in the Shangri-La of dentistry. I mean, you don't get better dentistry than what we can give. So
I would say mine is the unknown. Like that patient sat down in the chair, nobody at the front desk asked if they took their pre-medication or reminded them, and now I'm like, did you take a pre-medication? Like, you did, and now we got to figure this out. Or any changes in your health that we might want to know about prior to. Now I got to go figure out if you need pre-med or not. That slows me down. I didn't know that you just had an implant placed. Well, now I got to go figure out what kind of implant that was, when it was placed. Is it ready to be probed around? Why didn't we have that information beforehand? Like, the unknown gets me and pisses me off a lot.
So that's more of, interaction and communication. So,
Yes.
I'm not sure you could throw a product
No,
at that.
but then for me, it would also, I think it all comes down to emotional stuff too, is like being contradicted or not valued in my professional expertise, when the dentist might come in there and say, oh, nope, don't need a scaling replating, see you in 6 months. Like that. I know we always kind of come back to that, but I think that for me
you have to
is the
understand,
frustrating
I
part.
think Michelle and I are both pretty atypical hygienists, though, in our practice settings and
Maybe.
things like
Right.
that. So I don't know that we necessarily have the full
Like
representation.
a product that would like make you more efficient or
So the point I was trying to make is, if there was like a top 5 pain points in the practice, and you saw something at a dental meeting that would address 3 out of the 5 in a positive way.
Sure, yeah.
Right?
Yeah.
That's worth communicating, and if I was a business owner, I would listen.
That's absolutely right. I agree.
But I think it comes down to, how, again, the lack of communication between hygienists and dentists and their different points of view, and like, how can we be better communicators with each other so that we don't have this. And I think this is like a really good step in the direction. It actually kind of focuses the hygienist on the floor, on the exhibit floor, and like, well, where is the value in this product, and how could I make it good for my patients but good for the business side of it too. So this, I think, is a really valuable resource.
It could actually help the perception issue you're having, where maybe you're not taken seriously or whatever, because if you're presenting information in a certain way and it actually validates your position somehow, that's only going to help.
Right. Absolutely. Yeah, exactly. And I would even I haven't read all the way through this, but is there anything like with research on here?
Yeah.
Current
Is it
research
supported by research?
Yes. Like, is there something that's saying differently in the research now versus what we all thought once upon a time? Like, I think those things
yeah, I mean,
are like,
definitely add to it.
So I want to clarify.
Well, then you could just do your additional
in the
comments.
article. There is a link to a template.
Yes.
In addition to
The article.
and so don't gloss over, because I know a lot of people, when they see it's highlighted in blue, they just like, oh, this is a link for something else.
Yeah.
They could download it. Yeah.
Pay attention to that link when you guys read through this, because that's really important, and download it and then
And it's
edit it.
and it's a tool. I posted a link to the article, on several social media platforms, and I was pleasantly surprised at the positive response.
That's great.
Yeah, it's fantastic.
Something I was like, boy, I wish I wrote this sooner, but I got to it when I got to it.
Right, I know.
Absolutely.
So I know we're kind of creeping in on time constraints, but one thing that we also ask is there any words of wisdom or helpful advice that for students and new grads, or even the veteran hygienist, that you're like, if they only knew this like 5 years sooner as a graduate, a new student, or something like that?
I think they should start working on their personal brand immediately. And by personal brand, it's not self-promotion, but what do you stand for as far as integrity, knowledge, skills, and just live up to that, because
nice,
that personal brand follows you whatever practice you go to throughout your career. And basically you want to be known as someone who's a valuable resource in the practice. So start working on that. How do you embody that? How do you contribute? Be a contributor. And I think that'll take you a long way. That's how you become a mini thought leader in your practice. Every business, there's a dynamic. There are leaders and there are followers. Everyone can't be a leader. A lot of people want to be a leader and they fail because it's based on entitlement or ego or whatever.
Yeah.
But if you earn that leadership position, then you'll be respected, and you'll be the person that the doctor or the practice owner asks, what do you think about this? You will be the person that sets an example for new employees and trains them, and you become invaluable. So I think it's all about the personal brand.
That's a great one. Yeah.
We haven't had that one yet.
No, we haven't.
Really good one.
That's pretty nice. Well, thanks for your time.
Thank you for
having me. How can
people
people find you, learn more about the
I am
Patty's thing, or whatever you're
I'm
working
on Facebook, LinkedIn, Twitter. My website is Ventriello.com.
Can you spell that for us?
Sure. Nice Irish name with the O in the wrong place. Ventriello. And I'm actually in the process of redoing the website. It's about time, but it's like the shoemaker's children.
I know, goes without shoes, right? Absolutely. Well, thank you. We appreciate you coming and having this talk with us.
It's about that time. Grab your blanket and a glass of wine. It's story time with Michelle.
So, story time with Michelle is sans wine, unfortunately, because it's the middle of the day. Not that I'm opposed to drinking in the middle of the day, but I'm going to a spa event that will have lots of wine and champagne later. So I'm trying to not do that. And plus, I have to work. All right. So this is an article. So, I was listening. I myself was kind of binge listening to our own episodes. Some people might know this, but we both edit different portions of the episodes. And I sometimes listen to the interview section once you guys all listen to the interview section. Even though I'm present for them, I always don't remember what's happening. And so I listened to like Francis's and I listened to, Chris and Lisa. And there was a lot of little conversations or questions. And Edie did fantastic. High five, Edie.
She needs to be on more often.
Yeah, she did a great job. Asked really good questions. And some of her questions... What?
Can we tell everyone that Edie's going to be with us at Voices of Dentistry?
Sure.
Because I just said it, so either we edit that part out or it happens.
It's out in the world.
But Yeah. So she's going to be our guest on the stage at Voices of Dentistry when we present in January. And she's going to be talking about teledentistry. So,
Which is so
yeah,
cool.
come out and support her if you're in town.
Yep. Yeah. And don't forget about that. It's Salt Lake. Wait, where are we going? Scottsdale. I don't know where I'm at in half the time. Scottsdale, end of January, Voices of Dentistry. All the podcasters come out and hang out. It's pretty cool. So all those questions that Edie and you guys were talking about with like, I remember one about LNAP and like there being calculus left behind and all that kind of stuff. So I was reading up on an article because I was interested in hand scaling instruments and sharpening and things like that. So I found this one article, and it actually kind of summed up some of the things you guys were talking about. It is from Periodontology 2000, Volume 71. It's a 2016 article. It's Ultrasonic versus Hand Instrumentation in Periodontal Therapy Clinical Outcomes. And it's more of a systematic review, which is always so great. It is a super long article, like 15 pages, so I'm not going to do that to you because you are on your lunch break.
Thank you.
But what I wanted to do is just kind of highlight some of the things, or talk about some of the things I highlighted. And some of them were the things that you guys were talking about. So first one being the European Workshop on Mechanical Plaque Control, recognize, which we're going to. I'm so excited that we're going to be at that and actually hear this stuff firsthand. Sorry.
Yes.
So they recognize that meticulous plaque removal every 24 hours would be adequate to prevent gingivitis. However, most people do not remove all the plaque on their tooth surfaces every time they brush. A higher frequency of toothbrushing will result in better plaque control. And what I like about this, and I have been actually giving that piece of information since I was in my perio office like 4 years ago, because people are like, oh, I sometimes can't manage to brush twice a day. And I was like, well, the research shows that if you did a really, really good job once a day, that would probably be adequate for you. But do you think you do that?
Right.
Do you think you do well enough one time a day? And they're like, yeah, no, I don't. I was like, so that's why you have to do it more often. You know, it'd be like wildly sweeping your house and then going, oh my God, I didn't clean it well. Like, look how much dog hair's on the floor still. So I think that's a really great thing just to kind of keep in the back of your head. Like, you could only brush once a day if you did it well enough, but most people don't do it well enough at all. An early animal investigation showed that autoclaved calculus is only a low-grade irritant, whereas non-sterile calculus produces a mass of granulation tissue and a foreign body reaction with a tendency for abscess formation with connective tissue. In addition, they found that lowering the toxicity of the calculus by treatment with chlorhexidine gluconate permits the attachment of junctional epithelial to the calculus. So this is why I think LNAP works. And I kind of agree LNAP is, I've seen good results with it, but what I don't like is that they're not transparent with their protocols and the science behind it. They're just, they're a little secretive with it. And in what I hear from them and what they say, the reason they don't care if calculus stays behind is because it's sterile and the tissue actually attaches to it. As a hygienist, this drives me insane. But this is kind of backing it up a little bit, so it does act still as a low-grade irritant. The current general consensus among clinicians and clinical researchers is that cementum, although difficult to retain during calculus removal, need not be sacrificed for good therapeutic outcome. It appears that endotoxins adhere to root surfaces without penetration into the cementum, and it is binding to root surfaces appears to be weak. Root planing with hand instrumentation is able to remove root irregularities that harbor plaque and calculus and renders diseased root surfaces free of detectable endotoxin. However, it has been shown that gentler techniques, ultrasonic scaling, utilizing sonic or ultrasonic scalers are as effective in removing plaque and calculus. Isn't that interesting? So it's very weak attachment.
It's very interesting.
Okay, an earlier animal, oh no, I said that one already. Okay, these two types of curettes, they're talking about a universal and Gracie. These types of curettes differ in the area specificity the number of cutting edges, the curve of the cutting edge, and the angle of the face. So I was looking at different scalars. And reviews of various studies performed under different conditions and in different models have concluded that neither hand nor mechanical instruments are superior in removing subgingival deposits. Ultrasonic instruments remove less root structure than hand instruments, but leave behind a rougher surface. Hand instrumentation has been recommended to smooth the root surface after ultrasonic use as a final finishing procedure in the treatment of periodontitis affected roots. I just found all these little things very interesting. Sharpening. How often do you sharpen? Are you using XP? So you're not sharpening, right?
I'm XP, so I never sharpen. Correct.
Okay. So this is the thing that I talk to my students about because I have XP, but I also love, of course, my PDT instruments, and I do sharpen those. And I actually enjoy sharpening because I'm the weirdo. I get it. So this is what I tell my students when they're like, do I have to do this? Like, I just sharpened mine like Monday. I'm like, well, it's Friday, and you've seen 4, like, class 4 patients. Like, sharpen your instruments. So this one says O'Leary and Coffrey, I don't know if that's saying that right, recommended sharpening hand instruments after every 5 working strokes. Another one recommended after every 10 strokes, and another study recommended after every 12 strokes. Another, Zappa et al., found that after the first 20 strokes, there was diminished hard tissue removal and an increase in pressure applied per stroke. So it's totally unrealistic to sharpen every 5 to 20 strokes. It's just not practical and results in destruction of the original contour of the expensive instruments could happen. So most studies suggested that depending on the quality of the alloy and the pressure used for root planing, we may be able to retain sharpness for a greater amount of strokes than originally thought. So what I want to say is that I know you're sleeping right now. Oh my God, I hate you. But this also talked about the difference between XP and like really good alloy, and that was interesting. You can read it.
Okay, but finish your thought though. Like you're saying that, okay, because some say after 5, some say after 10, it's not realistic, blah, blah, blah. So what do you do? What is the answer that you're giving to our listeners?
So I would say
after every patient, before every patient?
Well, I think you keep track of what kind of pressure you're using and know your instruments. Do you have like retipped instruments where you don't know the alloy? Or do you know that you're getting like, let's say PDT's instruments or even American Eagle has the Talon Tough. Like those are very strong metals that actually keep their edge. So if you're only doing light pressure and you're only seeing these like class 1, class 2 patients every day, you probably don't need to sharpen. But if you're doing scaling and root planing and you're doing it often, I would always sharpen my instruments between quads. Like I didn't move on to the next quad without sharpening my instruments. I don't like to work harder.
And I don't want to derail you, but if you're doing it between quads, are you worried about leaving metal deposits?
Oh, well, I cleaned my
subgingivally
instrument off.
I know, but I feel like I've heard before that even if you like a 2x2 with like alcohol or whatever on it, and you just like take it off, like there's still debris and stuff that you're leaving.
Yeah, but if I do it before the patient is going to still be there too. Like where do you get it off enough that it doesn't matter?
But if you do it after the patients and then you put it through the ultrasonic and then you put it through the sterilization process, if you sharpen after the instrument. But if you do it afterwards, then you're going to increase your chance of
sticking yourself with dirty
transmitting
instruments.
infection. Yeah.
Which is definitely a case if you're doing it between quadrants too. But I know I'm a sharpened snob. Like Daniel has attested to this on mission trips. Like I don't want anybody doing my instruments because I want to make sure the edge is always perfect and always sharp because I don't want to work harder. And it's better for ergonomics. It's better for your hand health. Like there's so many reasons that you should be sharpening your instruments. And I use the Gleason guide, so it's super easy. It takes me like 4 strokes and I get an edge on it. And if you're consistent with it, you don't have to like kill the instrument to get the right edge again. Anyway, I could go on for days for sharpening.
Yeah, you could. Mike got his Gleason guide. Linda so generously sent him one.
Oh.
And he is like the envy of his office, apparently.
Oh, really?
So, yeah, everyone loves it. So thank you again, PDT and Linda, for helping us out with that.
No kidding. Let me go down because I kind of go to the conclusion. It talks briefly about local delivery of antimicrobials, which has been a requested story time with Michelle. I will get to that. This one only went into it a little bit, but it does talk about like iodine and bleach water solutions and all of that. So it's very good. Also versus chlorhexidine following root debridement. So it's a really good article, honestly. It really kind of sums up a lot of things for perio. So in the concluding remarks, non-surgical periodontal therapy involves mechanical removal and disruption of bacterial colonies from the tooth and root surfaces. This can be accomplished by hand, sonic, and ultrasonic scalers. Root planing with a hand instrument remove the root irregularities that harbor plaque and calculus. Root planing with sonic and ultrasonic instruments remove less of the tooth structure but leave behind a rough surface. However, both techniques are equally effective in removing plaque and calculus deposits. Sharp hand instruments are the key factor for clinical effectiveness. Just take a moment, soak that in. It is recommended that the hand instruments be sharpened every 5 to 20 strokes. However, this is not practical, creates metal tags, and changes the original contour of the instruments. Instruments also lose their efficacy after repeated thermal and chemical sterilization. In view of these problems, instruments with edge retention properties have recently gained popularity. Powered scalers increase the efficacy during non-surgical periodontal therapy by reducing operator fatigue and removing calculus more quickly than hand instrumentation. However, powered instruments create a rough root surface and increase root sensitivity. Powered instruments are classified as sonic and ultrasonic based on their working frequencies. The frequency, speed, and amplitude are important parameters to consider while using the power-driven scalers. Higher frequencies require higher energy output but result in smaller active area around the tip. Ultrasonic devices can be piezoelectric or magnetostrictive. Understanding their mechanism of action helps the clinician use them optimally and reduces the damage to the tooth structures and surrounding tissues. Chemical irrigation with antimicrobials as an adjunctive therapy has been shown to have added benefits during non-surgical periodontal therapy. Antimicrobial agents such as iodine, diluted sodium hypochlorite, which is bleach water, and chlorhexidine have been used for pocket irrigation during or following root debridement because of their potential bactericidal effect. Other local antimicrobials used include minocycline, doxycycline, and metronidazole. Non-surgical therapy can be accomplished in a single visit or in multiple visits. The advantages of using a multi-visit approach are that the clinician has multiple opportunities to observe and correct oral hygiene practices of the patient and to evaluate and treat any sites needing additional therapy. Sorry, I just needed to say that in a much higher tone because I think that is even more important sometimes than the scaling and replaying. That's my own professional opinion. Non-surgical treatment is the keystone to successful treatment of any patient with periodontal disease. It is important for the clinician to understand the different instruments used, adjunctive therapies available, and the best practices established in order to achieve optimal results. The end.
Well done.
You're welcome. This is a good art. I mean, it might take you like a hot second to go through it because like I said, it is 15 pages. But it really sums up a lot of things and compares them. It's always nice. I love those systematic reviews. So hope everybody enjoyed this week's episode. I don't think we're going to be anywhere soon together, but no.
Voices of Dentistry is coming up.
Well,
next year we have
January.
a lot of things coming up. So
Yep. And don't forget
in the
to
meantime,
share the podcast. Thank you again for interacting. Have you noticed how much people keep interacting on the Facebook page?
I know.
I love it.
It's so good.
Thank
you, everyone.
Our guests love it too, so we appreciate that. We also appreciate you sharing the podcast on other Facebook pages if you find it interesting or on your own, especially if you liked a particular episode. And leave us an iTunes review, right?
Yes, please.
Please. You can also email us at ataleoftwohygienists@gmail.com or send us a message through our Facebook page, which is A Tale of Two Hygienists. So hope everybody has a great week. We're coming up on the holiday season. Good luck to you all.
Have a good week, everyone.
Bye, y'all.
This is tough. I'm Italian. I use
I talk
my
with
hands.
my hands too. That's why sometimes I'm like, like this.
Whoa.
Knock waters off.